The abstract actually covers our single center real world experience using the two regimens. The first one is with the hypomethylating agents. That will be azacitidine or decitabine in combination with venetoclax and gilteritinib, or using a quadruplet regimen of low-dose cytarabine, actinomycin D, gilteritinib, and venetoclax. So the main difference is in the backbone. These are either hypomethylating agents or two chemotherapy drugs. So we've used these two regimens for FLT3-mutated AML here in Vilnius in Lithuania. And we have enrolled a total of 39 patients into the study, of whom 22 were female. The majority of patients were relapse refractory, 77%. The remaining 23% were newly diagnosed patients. The median age of the group was 65 years old, and the median ECOG was 1. FLT3-ITD mutations were more common in 70% of patients, whether the remaining 30% had FLT3-TKD or a combination of both mutations. So newly diagnosed patients received azacitidine, venetoclax, and gilteritinib, or decitabine, venetoclax, and gilteritinib. As for the relapse refractory patients, they were treated with the low-dose cytarabine, actinomycin D, venetoclax, and gilteritinib regimen. The overall response rates in both newly diagnosed and relapse refractory patients was 95%. The cumulative complete remission and complete remission with incomplete platelet recovery rate, that will be CR plus CRP, was 82% for all patients. So the efficacy was high. We are seeing almost all patients responding, and the majority of those responses are either complete remissions or complete remissions with incomplete platelet recovery. Half of the evaluable patients, so 50% of evaluable patients for MRD, had achieved MRD negativity, either by flow or by FLT3 PCR assays. All responses were achieved after one cycle of treatment. So what we do see that the venetoclax plus gilteritinib plus the backbone of either HMAs or chemotherapy are working really fast in achieving responses. Importantly, we didn't see signs of prolonged myelosuppression, and the median time for neutrophil and platelet recovery in responders was 25 and 23 days, respectively. There were a few cases of prolonged myelosuppression. However, all of those cases were in the relapse refractory subgroup. Importantly, 41% of patients were bridged to an allotransplant. And that is actually 80% when we take into account only allo-SCT eligible patients at baseline. So there were 20 patients who were deemed to be eligible for a transplant, and 16 of them could proceed to an allotransplant after achieving a response. So this is a good bridging strategy. The median overall survival was 25 months, and the median relapse-free survival was 8.2 months. Importantly, the early mortality was rather low. It was 3% at day 30 and 10% at day 60. And all of those cases were in the relapse refractory subgroup as well.